Good morning again. This is Dave Belusi at the WCIRB. Again, welcome to our research forum this morning on the early indicators of high-risk opioid use and potential alternative measures. Before getting into the substance and kind of introducing what we're going to talk today, let me go over a couple of things on logistics. As with all our webinars, if you could insert your questions, type them in the questions panel. We'll try to get to them as contemporaneously if we can. If not, we'll respond at the end of the session. Or if for some reason we didn't address your question or question comes up later, feel free to email at us at communications@wcirb.com and we'll respond back to you by email. Secondly, the handouts panel. Excuse me, having a little sound challenge. The handouts panel on the presentation has both the slides from this morning's presentation as well as a copy of the report that was released last week. So let me talk a little before turning it over to Dr. Shang. Let me just kind of summarize. Again, welcome to this presentation. As you know, advisory pure premium rates have dropped by more than 40% in California since 2015. The main driver of these reductions has been declining medical cost level. And the biggest factor in reducing these medical cost level really has been the dramatic decline in pharmaceutical costs. As in 2018, the average pharmaceutical cost per claim in California workers' comp was a little more than 20% of what it was in 2012. Many factors have driven this decline, including independent medical review, anti-fraud efforts, and the Medicare fee schedule changes that have worked their way into the California's pharmaceutical fee schedule. But a key factor has also been a very sharp reduction in the use of opioids in California workers' comp. There are really two components to it. The first is the impact of trying to wean injured workers who were heavy users of opioids off of opioids. Last March, the WCIRB published a study on this impact. The second component, which is the subject of this morning's webinar, has been the reduction in the number of workers who become high-risk users of opioids. You know, how does that impact the cost of a claim? What are some early indicators of high-risk opioid use? And with the opioid use declining, what alternative treatments are being used? Last week, Dr. Julia Zhang, the WCIRB's Director of Medical Analytics, and Yi-Chan Yu, another one of our really top flight medical researchers here at the WCIRB, issued a study on these issues that we'll be talking about this morning webinar. I'm going to turn it over to Dr. Shang, who will be summarizing the report's key findings. Julia.
Thanks, Dave. Hello, everyone. Thanks for tuning in. I'm very excited to share with you the key findings of our new study that focuses on early indicators of high-risk opioid use and potential alternative measures. My presentation will go through some background on the opioid use in the California workers' compensation system. I know Dave already mentioned a lot, but I will briefly walk you through some more. Our research questions, methods, some highlights of our findings, and we'll conclude with some takeaways. As you might have heard, in the California workers' compensation system, newer claims are less likely to receive opioid prescriptions. This graph is based on our data showing that the share of claims with at least one opioid prescription decreased from 45% of all claims that had any drug prescriptions in 2012 to only 10% in 2018. At the time of this analysis, 2018 data was still being submitted, but the downward trend is likely to continue. The significant decline in opioid use is likely due to collective efforts. These efforts include, like Dave mentioned, the implementation of independent medical review, the use of cures database to track the use of controlled substances, entire systems reaction to the national opioid epidemic, and most recently, the implementation of drug formulary that encourages prescriptions of non-opioid pain medications. Less opioid use have brought significant cost impact to the workers' compensation system. For example, the cost of opioid prescriptions per 100 claims dropped by almost 80% from 2013 to 2017. This precipitous drop in opioid prescriptions has also contributed to a lower level of pharmaceutical use in the system, which reduced the share of the total medical payment to pharmaceuticals from almost 20% in 2012 to only 5% in the first half of 2018. Now, what I'm not showing you here is that the types of injury didn't really change during the same period. So it raises the possibility that providers may have used alternative medical treatments as substitute for high levels of opioids to control pain. In our study, we were particularly interested in the following questions. What are the characteristics of claims involving high-risk opioid use, which I will define in a little bit? More importantly, what are the early indicators associated with high-risk opioid use? This information may facilitate early interventions that can reduce the cost and adverse effects of high-risk opioid use. We're also interested in the differences in the utilization patterns of alternative medical treatments, including both non-opioid drugs and medical services, comparing claims involving high-risk opioid use to claims that having lower doses of opioids. Lastly, we were interested in assessing if alternative treatment patterns change over time. We used the WCIRB's medical transaction data to analyze claims that had accidents in 2013 and 2016 with 12 months experience. We defined claims involving high-risk opioid use as those using 50 or more morphine milligram equivalents per day for at least 30 days. This is consistent with the CDC's threshold for high risk of opioid use. Lower dose opioid use claims were those use lower doses of opioids or for a shorter time period. We know that high-risk opioid use claims are very different from claims involving lower doses of opioids. For example, they were more likely to involve a major surgery, which I will show you in the next slide. So to ensure we were comparing apples to apples, we matched these two groups of claims on injured workers' age and injury mix. We use the CDC's ICD classification of pain and the major surgery type as a proxy for injury mix. Our analysis of the early indicators focused mostly on the patterns of opioid use in the first 6 months treatment after the injury. Our analysis of alternative treatment measures include both non-narcotic pain medications and physician services such as physical therapy, acupuncture, chiropractic care, durable medical equipment, and counseling, and others. We used a number of medical transactions per claim to measure the differences in medical service utilization between these two groups of claims. Lastly, we compared the medical service utilization on the newer claims to those on the older claims to assess changes in treatment patterns over time. From our analysis, we found that high-risk opioid use claims are significantly different from lower dose use claims. But first, how many claims involved high-risk opioid use. Among claims that had accidents in 2013, about 2.5% of them became high-risk opioid use claims, compared to 1.4% of 2016 claims. This suggests very positive progress in addressing the opioid crisis in the California workers' compensation system. The rest of the table listed some baseline characteristics that we matched to ensure we're comparing apples to apples. But I want to highlight a few. So high-risk opioid use claims were more likely to have both acute and chronic pain. They are also more likely to have a major surgery, and in particular, surgical procedures on the spine and the spinal cord, as well as the vertebral column. So given the sharply different characteristics, again, only with matching can we identify other aspects of treatment patterns that are predictive of high-risk opioid use, as well as alternative treatments. So all the figures and analysis results I'm going to show you in the subsequent slides are based on claims of similar age distribution and injury characteristics. We found that high-risk opioid use claims are significantly more costly than similar lower dose use claims, even after 4 years after injury. This graph shows that the median medical losses on lower dose, on high-risk use claims are twice more than those on lower dose claims. And the differences between the two groups became even larger when it comes to indemnity losses.
Yeah, I think this is a real interesting finding that, we always, workers' comp is always intuitive that there's a real connection between the medical process and the indemnity process. And these take claims that are very similar in terms of the age of the worker, in terms of the type of injury, the type of surgery, the CDC classification of the pain, and really compares their costs. So in one way, you can kind of look at these claims that are all similar, except one was a high-risk, heavy use of opioids, and the other similar claims were not. And seeing that almost 3-to-1 differential on the indemnity side is pretty interesting. Because again, what this really gives some indication that heavy use of opioid, high-risk opioid use was driving the indemnity cost, which means it was driving the temporary disability duration or the permanent disability rating, and having a differential of 3-to-1 close to 3-to-1 on both the medical and indemnity side really kind of supports that intuition of how the two are connected and how significant high risk of opioid use was as driving claim costs in California. And with the reduction in high risk opioid use that Julia has alluded to, really has been we think a significant factor in moderating costs and actually driving some of the costs down over the last several years.
Great. And one potential reason that high-risk claims incurred higher costs was that they are more likely to remain open. So on this graph, we can see that 1 year after the date of injury, high-risk use claims, 87% of them remained open compared to 65% of lower dose claims. And after 4 years after injury, the likelihood of staying open on high-risk claims were twice higher than the low-dose claims. So moving on to the 4 early indicators that we found from our analysis. The first one was obtaining similar opioids from multiple dispensers. We looked at both pharmacies and non-pharmacy dispensers. We chose to explore this indicator in our analysis was because literature shows that obtaining opioid prescriptions from multiple pharmacies or directly from physicians were associated with higher risks of prescription opioid overdose. In particular, getting opioid prescriptions from 3 or more pharmacies in a 6-month period would increase the odds of drug overdose by more than 3-fold. And from our data, we show on the left-hand side, high-risk use claims are at least twice more likely to involve multiple pharmacies, and similar patterns are shown on the right-hand side for non-pharmacy dispensers. The second indicator that we found was overlapping opioid prescriptions, which we defined as having more than one opioid prescription in a 7-day period. And overlapping opioid prescriptions were shown to increase the risk of opioid overdose by 3-fold. So our analysis also showed that high-risk use claims are 4 times more likely to have multiple opioid prescriptions at the same time. And the difference between the two groups actually enlarged in 2016 compared to 2013. The third indicator that we found was the use of extended-release long-acting opioids. So CDC's guidelines for opioid use recommend that physicians prescribe immediate-release opioids instead of extended-release or long-acting opioids to treat chronic pain because they were associated with higher risk of opioid overdose. And our data shows that high-risk use claims were 5 times more likely to use ERLA opioids. And that's true in both accident years. Lastly, we analyzed the concurrent use of opioids and benzodiazepines. So benzodiazepines are a class of drugs primarily used for treating anxiety. Because both opioids and benzodiazepines are potentially abused drugs, using these drugs concurrently is a marker of high risks of fatal drug overdose. And high-risk opioid use claims in our study sample in 2016 were 7 times more likely to take these 2 drugs together. Now, switching gears to our analysis on the potential alternative treatments. First, on alternative non-drug treatments, the graph shows the differences in the utilization of several types of services comparing low-dose opioid use claims to similar high-risk opioid use claims. Bars with positive numbers indicate more utilization on the lower dose use claims, and negative number shows the opposite is true. Let me focus on the 3 leading types of services, that is physical therapy, chiropractic care, and acupuncture. In the first 6 months of treatment after the injury, lower dose claims used significantly more PT, chiropractic care, and acupuncture than similar high-risk claims. The significantly more use of PT on lower dose claims was mostly driven by these 3 specific procedures and modalities, whereas more utilization of chiro and acupuncture were mostly from the use of this manipulative therapy on 1 to 2 spinal regions and electroacupuncture. I also want to point out that in addition to the service categories presented here, we analyzed other alternative treatments such as cognitive behavior treatment and functional restoration programs. However, these services were used significantly less than the ones listed here, limiting our ability to make meaningful inferences. To assess if treatment patterns have shifted, we compared service utilization in a 12-month period between newer claims to similar older claims. We did a comparison within lower dose and high-risk claims separately. So overall, 2016 claims were more likely to use acupuncture treatments regardless of the levels of opioid use. While utilization of physical therapy did not change over time, we observed some changes in the specific procedures and modalities. So 2016 claims were more likely to use, at least for lower dose claims, they were more likely to use therapeutic exercise, kinetic activities, and neuromuscular education but much less electrical stimulation. Moving to the alternative drug treatments, let's first look at the cost impact of reduced pharmaceutical use based on our study sample. We observed that lower dose claims used significantly less opioids as well as non-opioid prescription drugs, both contributing to 50% lower drug payments per claim. The cost savings from the lower levels of drug use were similarly significant on 2016 claims. And for non-opioid drug treatments, utilization of NSAIDs and non-narcotics were higher on lower dose opioid use claims than on similar high-risk claims. These aligns with California's medical treatment utilization schedule guidelines that support the use of NSAIDs and non-narcotics to treat chronic pain and may be suggestive of a substitution effect. In addition, we also analyzed the concurrent use of opioids and buprenorphine, which you may have heard as naloxone, as a recent development in drug treatments for opioid addiction. However, very few claims in our data and in our study period had used the buprenorphine, so our ability to make meaningful inferences was limited. When we assessed the changes in drug treatment patterns over time, we found that utilization of almost all pharmaceuticals declined significantly for both lower dose and high-risk claims. For lower dose claims in particular, NSAIDs and non-narcotics were used only slightly less on newer claims. These may suggest some positive substitution effects may have occurred. And high-risk use claims that involved more non-narcotics in 2016, but the number of non-narcotics per claim was very small. In summary, our analysis shows that newer claims are half as likely to involve high-risk opioid use. However, this smaller group of claims still involve high doses of opioid use for extended period of time. They were more costly and more likely to remain open even after 4 years after the injury. They were more likely to get similar opioids from multiple dispensers having overlapping opioid prescriptions. They were also more likely to use extended release, long-acting opioids, and concurrently using opioids and benzodiazepines. We discovered that physical therapy, acupuncture, and chiropractic care, as well as NSAIDs and non-narcotics, were used significantly more on lower dose use claims than similar high-risk use claims. These alternative treatments are consistent with clinical guidelines. Lastly, newer claims used similar amount of physical therapy, but more therapeutic exercise, kinetic activities, and neuromuscular re-education. So some changes in the mix of services were observed. They were also more likely to use acupuncture treatments. For pharmaceuticals, we observed significantly less of almost all types of drugs used on newer claims, except for very modest declines in NSAIDs and non-narcotics. These suggest positive substitutions may have occurred. So that brings me to the end of my presentation. I hope you find it helpful. Thank you for listening.
Julie, yeah, we've got a couple of questions from the group. One was asked for a little bit more description of your process for controlling for claims, identifying similar claims. Can you expand on that just a bit?
Sure. As I showed in the table, that high-risk use claims are more likely to have both acute and chronic pain, more likely to have major surgery, and in particular some surgical procedures. So our matching process resulted in two groups of claims with similar distributions of age, and if one group had 50% more higher likelihood of a major surgery, after matching, the other group will also have the same likelihood of having that major surgery. So the primary goal of the matching is to make sure that when we were identifying early indicators and alternative treatments, we were not comparing apples to oranges, and we are identify those within claims of similar age distributions and injury characteristics. Hope that answers that question.
Thank you, Julia. Great. So we also received a question of whether we tried to identify the high-risk opioid use. Was it concentrated at relatively few providers? Did we do anything that looked at the sort of the concentration of the providers that were providing services where there was high-risk opioid use?
That's a great question. In our data, we have very limited information on providers, so we use the dispensers as a proxy to look at the source of obtaining either multiple opioid prescriptions during a short period of time or different prescriptions from multiple sources. We would love to investigate more in terms of whether the high-risk use claims were concentrated among a few number of providers.
Great. We also received the question of, did the analysis look at behavioral aspects and treatments such as cognitive behavioral therapy and emotional awareness? Did we try to look at how frequently that was involved?
Yeah, that's also another good question. We looked into the cognitive behavior treatment as a potential alternative measure, but our data had very limited number of claims using the CBT, so we were not able to make any meaningful inferences. But we will keep monitoring the use of CBT. For the other one, emotional awareness, that's a very interesting point. I'm not sure our data is able to measure that. It seems very subjective, and our data is based on insurance billing and claims data. So I think maybe in the future we can explore other data sources to measure the emotional awareness.
The question is, you identify 4 early indicators of high-risk opioid use, like multiple dispensers and overlapping opioid prescriptions. Were there other indicators that you explored but didn't find to be significantly different between the two groups?
That's a good question. This project has a very long life cycle. Let me just think back. We explore physician-dispensed drugs in particular, which is slightly different from non-pharmacy dispensers, and we didn't find the differential use or differential use in physician-dispensed drugs between high-risk and low-dose claims.
Great, thank you. I don't see any more questions. So again, thank you, Dr. Zhang, for sharing the results, and thank you all for participating. And as always, we appreciate the feedback and the participation, and hope you have a good day. Thank you.
Thank you.